अऊज़ु बिल्लाहि समीन अलीम मिनश्शैतानिर रजीम बिस्मिल्लाहिर रहमानिर रहीम। खुदा ताला आली कदर मुफद्दल मौलानी उमर शरीफ ने तारोज़ क़यामत दराज करे, आमीन। અને આપ મૌલાના વસીલાસી अपन सगला मुमिनीनની હિફાજતમાં રાખે અને ખાસતન હેલ્થ કેર પ્રોફેશનલ મુમિનીનને મુમિનીનની ખિદમત કરવાની યારી અતા ફરમાવે. Welcome and thank you for attending the Saifi Burhani Medical Association America's 6th webinar. Today's topic is Diabetic Eye Complications. Before introducing our speaker, just a few announcements. You will be muted by default throughout this webinar. If you are using a mobile device such as a smartphone, we recommend that you change your orientation to landscape mode for better viewing experience. Throughout the webinar, you can type in your question in the Ask a Question box on your screen. After typing your question, click Send. We will respond to these questions near the end of the webinar during the live Q&A session. If you are experiencing any technical difficulty, please WhatsApp message at 818-267-6655. Lastly, any information provided in this webinar is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information, is for general information purposes only. Saifi Burhani Medical Association America, SBMAA, nor any of the speaker makes no presentation and assumes no responsibility for the accuracy of information contained in or available through this webinar, and such information is subject to change without notice. You are encouraged to confirm any information obtained from or through this webinar with other sources and review all information regarding any medical condition or treatment with your physician. Never disregard professional medical advice or delay seeking medical treatment because of something you have read or accessed or been presented through this webinar. SBMAA nor any of the speaker is not responsible nor liable for any advice, course of treatment, diagnosis, or any other information, services, or products that you may obtain through this webinar. Now, regarding today's webinar, today our speaker is Dr. Mullah Sakina bin Jamali. Dr. Jamali is an optometrist practicing at Kaiser Permanente in Woodland Hills, Los Angeles, California. She previously served as a professor of optometry for University of California, Berkeley School of Optometry, helping to train the next generation of eye doctors. She has been serving the Southern California area for over 20 years as a clinical optometrist with a focus on eye pathology. So without any further delays, we welcome Dr. Sakina bin Jamali. Dr. Sakina bin.
Shukran Hatim Bhai for the introduction. Welcome everyone. I'm going to be talking about diabetic eye complications in a very general sense, also because I understand that there are some audience members who are just Muminin, who are non-medical professional, who are interested in learning about diabetic eye complications. Okay, so we are going to focus on different topics. I've kind of broken it down into 6 different issues. The main one is diabetic retinopathy, which has 4 stages, and I will go over all the stages. And then the second one is diabetic macular edema. Third one is cataracts. Fourth one is glaucoma. Fifth one is neuro-ophthalmic problems. I'll explain more in detail about all these. And the 6th one, I've just kind of combined a few things and put them in together. Just in a general sense, diabetic retinopathy, diabetes is one of the leading causes of blindness in the United States. In the world, a lot of times it's refractive error. People just need glasses to see better, and that's kind of making them visually impaired. But in America, diabetes is one of the #1 causes, besides macular degeneration and cataracts. So it's very important to know what happens to our bodies and eyes when your blood sugar is not under good control. Now, usually you don't start having any diabetic problems until you've been a diabetic for like 10 to 15 years. Most of the time, if you are out of control to begin with, like your hemoglobin A1C is 13, 14, then a lot of times I'll see patients on day one with these changes because they've been undiagnosed for so long. So I always tell my patients that if I'm telling you you need to go get a blood test for diabetes, it's a bit late. That means that all these changes have been happening to your eyes and the body for a long time. So it's very important to be, cognizant about getting routine eye exams and routine physicals. I always tell everybody that. So let's start with diabetic retinopathy. So as I said, it has 4 stages, okay? And retinopathy means that you are having changes in the retina, which is a back layer of the eye, which is actually part of the brain. So just like the brain, if there is any damage done to it, a lot of times it can be permanent, especially if it's nerve related. It can cause permanent loss of vision. So that's why it's very, very important for you to be controlling the blood sugar in a stable level and not let it get out of control. So the first stage, we're going to call it mild non-proliferative diabetic retinopathy. And in that case, you can, so if anybody, all the medical professionals probably have seen the back of the eye at some point in time, so you kind of know that this is the optic nerve and then the blood vessels. It looks like a planet, kind of. When you look in the back of the eye, it's pretty cool. The blood is usually contained within the blood vessels. So when it's outside, that means that that's not normal. It should be within the blood vessels. So you start seeing like dot and blot, there's tiny little bleeding areas that form on the outside of the blood vessels, usually within the center of the eye, the middle part. That's where the most common changes happen. It's called the posterior pole. So when we look in the eye, the straight ahead, okay? And then the clear area is the macula, and that's where you don't want anything to be happening because that's where your eye is using that information to see most of the time. A lot of times, these changes are happening in both eyes, okay? And this is considered pretty mild. So usually I'll just tell patients, hey, you are having these problems, start monitoring it with your doctor, and we will recheck your eyes depending on the severity within 6 to 12 months. We'll usually take a photo, which is going to look very similar to this one. And we do both eyes, and then we watch it. If it's getting close to the macula, I'll usually see them in 6 months. Most of the time, though, if they're in stage 1 year is plenty, okay? And if you're not having any changes, I would say you need to get your eyes checked once a year as well, okay? So now we go to stage 2, which is, as you can see, it just looks a little bit worse than the last one. The blood, you can actually see the blood on the outside, and you also see these whitish spots. They're actually called cotton wool spots, just like it looks. It's an area of the nerve fiber layer that's not getting enough oxygen because of the weakening of the blood vessels. So you're losing blood flow in that area, and it looks kind of fuzzy. It means that the nerve fiber layer is hurting and you're losing vision in that spot. You also get changes in the blood vessels where it starts beating a little and kinking in certain areas. And because of the out of control blood sugar, there is not good blood flow going on in the rest of the eye. Now, keep in mind, these are things we can see. It's, we can dilate the eye and we can take a look, but these are similar changes probably happening all over the body. Kidneys are prone to, everywhere. So the eye is something we can see, but these changes are happening all over the body. So we care about the eye, but we also care about the whole body, and we always make sure that patients understand that you can lose your legs, you can, have kidney problems, you can have strokes, heart attack, and if your sugar is under good control. So when somebody comes in with moderate level, I'll usually contact the doctor, tell them that, hey, this is going on. Are you aware? Are you changing any treatments? Let's get this blood sugar under control, lower it a little bit, whatever it takes. Sometimes they have to go on insulin. And I'll usually see them every 3 to 6 months. A lot of times, if I'm concerned, I'll order additional testing, which this macular OCT I do quite a bit. If I'm seeing any bleeding near the macular area, which is the clear area I was telling you about, you can get pooling of the blood and the fluid, and it can disrupt vision very quickly. And that is something we need to address pretty fast. So this is something we can do in the office. It takes 2 minutes, and it gives me more information if there is any fluid coming close to the macular area. And then sometimes if it's getting worse, then I'll also order a fluorescein angiography where they actually inject the dye into the vein and take some photos of the back of the eye. And then it gives the doctor an idea of where are the, danger spots where the blood is not flowing properly and where we can watch it a little bit more. So we're already now we go to stage 3. So this is happening all over the eye now, in all the corners of the eye. And you're getting these big bleeds, okay? And as you can see, the yellow spots are getting worse. They're exudates, so it's like all the different parts of the blood are accumulating in different parts of the retina. And there's a very good chance that this person, is going to lose their vision if you don't do anything about it. So prophylactically, a lot of times what we do is, remember what I told you in the beginning, is the reason that this is happening and then you're getting these cotton wool spots and areas of non-perfusion is because there's all this need for the eye to get oxygen and it's not getting any. So what you do is you do laser treatments all over the eye, which is called pan-retinal photocoagulation. So you burn the retina. So you decrease the need for the oxygen to the eye to prevent further complications. So you don't want the eye to go into stage 4. So if you can prevent that, then even better. Otherwise, there's a chance that they will lose the eye. So again, I will always, in this stage, I send them to retina to do the fluorescein and consider pan-retinal photocoagulation. Now, let's say all failed, and lo and behold, this person comes in, and they're at stage 4. Now, this one, so the eye has been complaining and going through all these different stages, and now you are at a stage where it's like, okay, I am done. I'm not getting enough oxygen. I'm going to start helping myself. So it starts growing new blood vessels, most commonly near the nerve, which is the circular disc right here. And then you can see the abnormal looking vessels that are actually made by the eye to say, hey, feed me, I'm starving. This is very dangerous. This means that these vessels, because they are new and they were not originally there, they are weak. So they bleed very easily. And when they bleed, the whole eye, the vitreous gets covered in blood. You can get them on the other sides as well, but most commonly you get it on the disc. This is a pretty advanced case picture. I mean, usually we would want to catch it when it's much smaller. It's trying to find like drastic photos to show. So a lot of times in this case, if somebody is in that situation, they are going to get a bleed if they don't already have one, or they may get a retinal detachment because the new vessels are going to pull the retina, and then the patient will need a vitrectomy, which is a very advanced surgery where they actually drain the eyeball of the gel and put in a new liquid and an air bubble, usually to flatten the retina and treat it. Or if the bleed is really heavy, they need to clean out all the blood. But again, you need to cure the problem, so they'll need to do pan-retinal photocoagulation. But now, this was the only treatment earlier. Nowadays, they have these injections that they can do after. So it's not only injections, you have to do both. You have to decrease the need. You still have to do pan-retinal photo, which is PRP. And then you do these injections to, they're called Eylea, Avastin, there's Lucentis, there's different ones. They're actually chemotherapy medication. They actually shrink the new blood vessels. So, and they absorb the fluid. So it works well. It is probably in the last 20 some years that it's been out, and they keep getting better, but it is something you have to have an injection inside the eye every 4 to 6 weeks, depending on the condition, for the rest of your life. It's not fun. Okay, so this, usually a lot of times people end up losing the eye, they go completely blind. This is end stage. Okay. Now we're gonna go to part 2. So we're gonna switch gears, okay? We're gonna talk about diabetic macular edema. I already talked about the macular area a little bit, where I said it's the sensitive part of the eye. It usually, it's clear. You want it to be clean and clear so that all the vision can, that's where all the rods and cones live. So you get most of your vision from there. Cones. Rods live on the other parts of the eye as well, but the concentration of your visual acuity comes from the macula. So imagine anything happens to it, you lose vision very quickly. So this is the macula OCT I was telling you guys about, the bottom picture here. It should be flat, but see, you can see the little bubbles. That's actually fluid accumulating and causing the vision to go down. And in the colored picture, you can see the yellow exudates. Those are the hard exudates, and there's actually, this is a 2-dimensional photo, so when we look in the eye, we see 3-dimensionally, and we can see that there's fluid building up in there, and that's what's causing the vision to go down. The nice thing is that you can treat it nowadays, okay? It is not ideal, but you can treat it. In the older times, we used to do laser to treat this condition. They would do focal laser and burn the macular area, and it would basically mean that people would lose vision. There was no recovery at all. Nowadays, with Avastin and Eylea and Lucentis, you actually can do injections, and people do recover pretty well. You can get vision back. Not 100%, they'll still have some distortion. They may see like waviness or just kind of like blur, or certain areas are missing, anything like that. But when we do the OCT, we do see there is absorption of the fluid. So that's, again, it is something that we have to watch every 4 to 6 weeks. We do the OCT, and if there is any fluid, you get the shot in the eye. And it's for the rest of your life. They realized that when it first came out, they used to do it until the fluid was gone and thought that it was it. But now they realize that no, it is something lifelong. If you stop, the fluid will come back. But it is not like if there's no bleeding, then they don't have to. But again, the bottom line is if your sugar level is under good control, then you don't have to worry about these things. People can be diabetics for a long time, 15, 20 years. And if your sugar is stable, then you're good. That's the main thing. Keeping the sugar not only low, but stable. The fluctuations can really cause all these issues. The body goes into kind of shock. Okay. Now we're going to talk about something a little milder, which is pretty treatable, which are cataracts. So diabetics get cataracts pretty commonly, but they don't normally get like regular cataracts that you get when you're 80 or 70. They get something called posterior subcapsular cataract, which is more vision threatening, and it goes at a more faster pace. There's a picture of it right here. It forms a plaque in the back of the eye, which is in the center. So a lot of times age-related cataracts happen more. It's like yellowing of the lens, or you get peripheral changes. But when you have a diabetic cataract, they happen right in the middle. Now, diabetes is not the only reason that you would get something like this, but this is most commonly seen in diabetics. Steroid use can also cause these kind of cataracts. But the good news is usually you can do surgery and people recover and restore their vision back to normal. So that's the good news. And it's not, in this day and age, I don't consider cataracts a disease. It's actually pretty normal. I get a range of patients from 50 to 90 who need cataract surgery. I even send 90-year-olds to get cataract surgery, and they do really well. The only thing is, because diabetics have a weaker immune system, they tend to actually get more complications post-op, and also they're more at risk for getting macular edema, which I talked about earlier, after the cataract surgery. So they just take, instead of like 2-3 weeks, they can take up to 6 months to recover their vision fully. And we just have to keep them on steroid drops or anti-inflammatory drops for longer periods of time, which is, not the worst case scenario, but it's frustrating for people. Okay, now we are going to go on stage 4, which is glaucoma. So we're not stage 4, it's just a level 4. So it's a different type of disease. Now glaucoma, I'm sure you guys have all heard of it. When you go get an eye exam, you get this puff of air that people are like, oh yeah, we're going to do a glaucoma screening. We're checking your eye pressure. It's pretty common. And it's a good screening tool. Diabetics, though, are at, almost 40% more increased risk for getting glaucoma. And the worst case scenario, again, remember the new blood vessels I was telling you about happening in the retina? That can happen in the colored part of the eye as well. And you can get neovascular glaucoma, which is very severe. And most of the time, drops won't cut it. You need to have glaucoma surgery to control that. Now, here's a picture of pretty advanced primary open-angle glaucoma. Diabetics do get primary open-angle glaucoma. There are different types of glaucoma. You can have high pressure, or you can have normal pressure, or you can have low pressure glaucoma, low tension. So diabetics, because their blood vessels are not healthy, again, for the same reasons, because the sugar is interrupting all, the tissue, it's causing tissue damage. So it's not getting good blood flow. So guess what? It's going to start killing the nerve tissue. And this yellow that you see is going to get bigger. This is actually a hole that's taking the information back to so it's actually an opening. So imagine a tube, okay? And what you're seeing is the end of the tube. And the end of the tube just gets bigger and bigger as you're losing more nerve tissue. So it's like an excavation, basically. If you go for routine exams, which I would really highly recommend for everyone, that you should get an eye exam at least 1 to 2 years, even if you don't have any health issues, you can pick up glaucoma on routine exams. People have gone for LASIK consultation and were told that, oh my gosh, your pressure is really high, don't get LASIK, you have glaucoma. And then we get, 50-year-olds coming in like that in our office. So basically, if you have glaucoma and your pressure is high, it's easier to treat it because then we can lower the pressure. If the pressure is normal, it gets very tricky because it's like, how low can you go? Drops only go so far. So then you have to talk about laser surgery or glaucoma surgery, because the only treatment we have for glaucoma is to lower the pressure as much as we can. You end up having glaucoma filtration surgery, the eyeball becomes super soft, you're more prone to complications. And so one thing I want to mention about glaucoma is people are like, oh, I don't feel anything, everything's fine. No, you're not going to feel anything. Even if your pressure is 30, you're not going to feel anything. Normal range is 10 to 21. Even if your pressure is 30, you may not feel. If it's 50, you're going to have pain. That's a different type of problem. And that's, it can happen in diabetics, of course, but that's angle closure glaucoma, where the angle is completely closed and the pressure is shooting up, and that severe risk of losing the eye. So all I'm saying is that, go for a regular checkups, because you will not know until it's late that there is something wrong. It's preventable. I mean, you can reverse it. Again, it's the nerve. Okay, so you can reverse any damage that's occurred already, but you can prevent further damage with good control. You have to be good about, using the medication, and you have to be good about following through. Okay, so neovascular glaucoma. Again, this is the worst type of glaucoma you can have, unfortunately. It's very difficult to control. Most people end up losing the eye just because the pressure goes high. There is damage in the delicate tissues where the fluid is being formed and it's not able to drain because the new blood vessels that I was talking about, neovascular means new blood vessel growth in the angle, and it's preventing the fluid drainage, and you get this fibrovascular membrane, it grows, and there is a very, very advanced picture of iris rubeosus. I hope I never see that in my lifetime. I've been doing this for 20 years. I've never seen it this advanced, because in America, people usually have good health care. But there's this reddish blood vessels in the colored part of the eye that you may see if you look carefully. That's not normal. Those shouldn't be there. And this is extremely advanced. This person is probably going to end up going blind. They will need glaucoma surgery, they'll need laser, they'll need everything you can think of to control this. Again, I was mentioning the secondary angle closure glaucoma. So what happens is the blood vessels in this picture, they have this fibrous material, and they're blocking the angle where the fluid is draining normally, okay? Because the fluid is being produced in the eye all the time. But if there's something blocking it, then you can get secondary angle closure glaucoma. Again, to treat it, you need to reduce the need for oxygen, okay? So you're gonna do the laser. Most likely this person also has diabetic retinopathy and neovascularization of the disc, so they're probably gonna need laser. They're gonna need, glaucoma drops to lower the eye pressure, and probably surgery, like a filtration surgery or something advanced, because laser is just the laser to reduce the pressure is not going to cut it. Okay, So again, this is pretty advanced stuff. I hope that nobody ever gets into that stage. Okay. The other thing that happens pretty commonly, I see this probably once every few weeks, is neuro-ophthalmic issues from diabetes. Okay, this is a different topic again. So what happens is diabetics suddenly wake up and they see double. And instead of one, if they close one eye, yes, they see single with one eye. But if both eyes are open, they see double image. And it's because there's a palsy in one of the nerves that is controlling the eye movement. Okay, sometimes you can have pain with it, sometimes not. So if you ever wake up and you are seeing double, please go to the emergency room or and get somebody to see you, because first of all, it could be a stroke. This if it's from diabetes itself and you don't have any stroke, you had a scan done and everything's fine, then usually it will recover fully. You may just have to wear a patch for a few months and you will recover. So it's not a big deal, but it's very debilitating. People get very scared when they go through this, and you just have to reassure them, and it recovers most of the time all the way 100%. Sometimes they end up needing a little prism to control the double vision because the muscle never goes back 100% back to normal. The other thing is the swelling of the disc. Remember the oval, the round shape, the center image that I was showing you? That's actually the optic nerve head, and you can get just swelling in the nerve. So the nerve is getting swollen from uncontrolled diabetes. This is actually not that common. It happens more in juvenile onset diabetics. Most of the time, if I see any kind of nerve swelling, I will worry about neural problems like tumor or multiple sclerosis is a common one, MS, that will cause, especially if it's one eye. If you get swelling in one eye, there are other benign conditions can cause swelling in the eye as well. But most of the time, it's something you need a scan right away, and we need to monitor pretty closely. Believe it or not, this will recover on its own in 3 to 4 months. If it's just acute and it's from diabetes, it will recover. But usually these kids are on insulin and they have pretty good sugar control from their pump. All right, now we're going to talk about lighter things that happen. This I see on daily basis, probably. Dry eyes and prescription changes. When the sugar is out of control, you can get swelling in the cornea, you can get swelling in the lens, and it will cause your number to fluctuate. So depending on how high your sugar is, there may be hours in the day where you can see fine, and then suddenly you may notice that, oh my gosh, now I can't read anything, and it can last up to a few hours. The thing that I see most commonly is when somebody gets, let's say somebody is a new diabetic, okay? They get put on medication, and they start taking their medication. Their sugar levels are going down. For some reason, at that time, the eye goes into like complete shock, and you will have a drastic prescription change for about 3 to 4 months. If they were wearing glasses for far, suddenly they're like, oh my gosh, I see everything perfect. Now I can't read. It reverses. Or they'll be like, oh my gosh, I used to be able to, see far. Now I can't. So it could go either way. It just depends. We cannot predict. It could be a hyperopic or a myopic shift. At that point, you just have to hold their hand and say, hey, just bear with it. You try to make do with something. Either they get a cheap pair of glasses if they can't drive at all, then you usually prescribe something so they can survive for the next few months before we can finalize their prescription or once it comes down. Or you can tell them, hey, go get some over-the-counter reading glasses until you get through this period. So it's again, it's very scary for patients, but this will get better. The other common problem people have, even non-diabetics, dry eyes. Dry eyes are like 90% of my patients have dry eyes. Young, old, everyone. It's so common because of all the devices we use, environmental changes we have. You can present with burning, foreign body sensation, watery eyes. And it's sometimes it can even make you feel like, gosh, my vision is so blurry. Something is really terribly wrong with my eyes. Believe it or not, just a simple eye drop, refresh tears, or any kind of sustain, any over-the-counter good ones. I would say use name brand. Try not to get generics because they do have preservatives that can irritate the eye a little bit more. So stick with name brand. They tend to be a little bit more expensive, but refresh or sustain, any of those are really great for solving this simple problem. A lot of patients wonder about prescription medication for dry eyes. They actually work for very specific type of patients, people with autoimmune diseases like lupus or rheumatoid arthritis. It helps for them, but even then, it can take up to 6 months to work, and it doesn't work that well. So there are 3 or 4, there's 2 or 3 different ones out there, but honestly, none of them work as well as just pure moisturizing. I always tell the patients that make sure you hydrate well. Drinking water is very important when you have dry eyes, especially for young kids if they're having these issues because of all these Zoom classes and iPad and phone. Make sure they're hydrated, and using artificial tears as needed will solve a lot of problems. Punctal plugs is another solution that we can do. So basically plugging like the sink from, so we plug the puncta where the fluid is draining. We put a little plug in there and it works, but it still doesn't solve the problem because, the eyes are dry, so you need to still moisturize, but it can help quite a bit. The other thing that diabetics go through because of their weaker immune system is they're prone to infections. Okay, this you guys know, general practitioners know all the time, that if you have a diabetic, you want to treat them early, treat them aggressively, even if it seems like a little infection, they can get out of control pretty quickly. Okay, and I had kind of promised that I would discuss some of the things that you can do in your offices. Some of the doctors who, if you guys have a fundus camera, great, then make sure you take a photo for all the diabetics and you can monitor. And if you see something that you don't know, please just refer them to an eye doctor who can take a look and decide. I've seen some primary care doctors try to look with an ophthalmoscope. That's, to be honest with you, I never use it, and I've been doing this for 20 years. It doesn't give you that great a view. You are missing so much with that. So I would highly advise either invest in a fundus camera and take pictures yearly. And if you see anything, then just send them away because it may be bigger than you think. Unless you're an endocrinologist and you have knowledge, then. But anytime you have any doubts, send them to an eye doctor. And the other thing, like if anyone has any sudden loss of vision, like you wake up in the morning and you can't see, even if your vision is wavy suddenly, that could be macular edema. So make sure you get in right away because the earlier you treat any of these problems, the better. if you have any flashing lights, any floaters. Floaters can be normal, but again, floaters can be indicative of like blood in the eye or anything like that, or an infection in the eye. So you want to get that looked at right away. If you have any questions ever, I'm usually available. I prefer WhatsApp. If you can WhatsApp me, especially with a photo or some, doctor's notes, then I'll be happy to give you my feedback and or give you a second opinion, what's going on. I'm always happy to help. Okay, so thank you very much for listening. I hope you guys learned something about your eyes, and please don't hesitate to ever contact me with any questions.
Shukran, Dr. Sakina bhen. Aapno ghano shukran. We have few questions for you.
Okay.
Question number 1 was, if I have diabetes, how many times do I have to check my eyes?
Okay, I think I answered this question, but I will just repeat myself and say, so if you are a diabetic and you are under good control, then I would say once a year is fine. Get a fundus photo done and make sure they do the diabetic screening, which is they take a picture. It's pretty standard. Most people have a camera. And if there is nothing going on, then you're good once a year. If there's anything going on, then I would say 6 months.
Got it. And there was, I believe, a follow-up question on this. And the question was, is the checkup also required for pre-diabetic patients?
Yes. I would say yes. As I said, for anyone, because you can have any of these problems earlier, because sometimes pre-diabetics have high blood pressure or they have high cholesterol. So you can have these vessel changes. Sometimes I see bleeding in different parts of the eye, even in non-diabetics. So I would say once a year for everybody, especially if you're over 40.
Got it. Okay. Now, I think one of this question was regarding the stages you discussed earlier during the presentation, and it is, how rapid is the progression from one stage to another stage? I believe from stage 1 to stage 4.
Yeah. So again, it depends on the blood sugar control. Sometimes I'll see people right off the bat with stage 2 or 3. That's how you diagnose them. And so it depends. If you are in a country or a place where the healthcare is not available, then you will. But a lot of times these people, once they get on medication, they do recover. So there is no time. I can't give you any timeline. I have patients with stage 1 for 20 years, and then I have patients who go from stage 3 to 4 within 6 months. So it really varies. It depends on your sugar control. If you were out of control for a long time and you've been a diabetic, I would say most people start having changes in 10 to 15 years. But again, with good control, you may never get there.
Got it. Okay. So the next question is, why do diabetic people, when they drive in the evenings, it is very difficult to drive?
So that really depends on individual reasons. It shouldn't be just diabetics who have that problem. If you have good eyes, you shouldn't have any problems seeing in the evening. If you have cataracts, again, diabetics are more prone to cataracts. Or by the evening, if you had a big meal and your sugar is out of control, you can have blurry vision from that. So again, just work with your nutritionist, make sure your sugar is stable and it stays in good condition. It's not only sugar, we're talking about carbs are a big issue for diabetics. So it's better to work with a nutritionist so you can control all that. And the best thing to do, sometimes it's just dry eyes that is causing the blurry vision in the evening. Maybe a little drop before you drive in the evening will help. But if you have early cataracts or something, that can also cause that. I hope that helps.
All right. Thank you. So the next question is, do eye complications usually occur before kidney failure, heart attack, or strokes? If so, can we actually use eye exam to help predict risk of these things?
I think they're usually together because I have patients who have diabetic retinopathy. They already have the kidney disease. So I don't think you can. That's why I was saying in the beginning that if I'm the one diagnosing the diabetes in your eyes, it is too late. That means that your kidneys are already hurting. So it's usually concurrent. It's happening together. Eyes are not. So I wish we could do like diabetes like screening. No, it happens together at the same time.
Got it. The next question, a lot of diabetic complications occur from lack of oxygen. Is there any data on using hyperbaric oxygen chambers to help diabetic retinopathy?
I think, honestly, I don't have the answer for that, but because it's within the blood vessels, the oxygen has to come within the blood vessels. I don't think it would help because of the blood-brain barrier, the oxygen will not penetrate. And the cornea will not allow that kind of oxygen to go in. So it won't work. I mean, if you're talking about cornea, so people who wear contact lenses on, long periods of time can get neovascularization of the cornea. In that case, maybe a hyperbaric chamber would help, but not for that. I honestly don't think so, but I don't have proof of that. I don't have any, I would have to look into that because I don't know. But in my experience, I don't think it will work.
All right, Dr. Sakina. The next question is, as an eye doctor, how often are you the one to make a first diagnosis of diabetes?
If I have to give a percent, I would say probably 10 to 15% of the time, which is, I think it depends on the area you're practicing. If you're practicing in a lower income area or then it's probably higher. Most of the time, I'm hoping, as I said before, that I'm not the one diagnosing it. So it's pretty rare. I mean, not that rare, but pretty rare. A lot of times it's more the vision going in and out, or they have drastic changes in their numbers, or they get these little bleeds in the eye, things like that. But yeah, more commonly though, cholesterol, I do pick it up on younger patients, especially because they get arcus in the cornea. That's something I will be the first one diagnosing that a lot of times. But I would say 10 to 15%.
Got it. Okay. What to do if blood sugars are well controlled, but eye disease is getting worse?
If that is the case, then you have to look into what could the secondary causes of that. It could be high blood pressure, it could be cholesterol. Sometimes I'll send patients for ultrasound of the neck to see if there's any blockage there that's causing the lack of blood flow in the eye. Because there's, if you have good control, truly good control with the hemoglobin A1C under 7, and you don't have any other health issues, you shouldn't. But if, let's say I have a patient with one eye that's really bad and one eye is normal looking, again, I'll look at the neck and I'll send them for an ultrasound to make sure they don't have any blockage there. And that happens sometimes.
All right. Next question. What do you think about Restasis for dry eyes?
Yeah. So that's the drug I was talking about. Restasis, again, if you have any autoimmune diseases like rheumatoid arthritis or lupus or anything like that, Restasis may work, but it will take tremendous amount of patience. It doesn't start working until 3 to 6 months, and it burns a lot. You have to use the drops consistently. So I'd say yes. Unfortunately, I work for Kaiser. Kaiser is very not liberal about their prescription medication. So, but I used to prescribe it a lot when I was practicing as a private practitioner. But I still think that artificial tears, punctal plugs, are the best. But people who have severe dry eyes, Restasis is definitely my choice for severe dry eyes.
All right. So 2 more questions. If you have high blood sugar and sudden loss in vision levels and cataracts in eye, is there a way to see back of eyes?
You have to do an ultrasound. So you can do B-scan, which is an ultrasound of the eye to look past the cataract, which is very tricky. There is, different types of equipment we use. Again, the Macular OCT will give us a little bit of information of what's going on in the back of the eye, but sometimes we have to send you for a B-scan, which is an ultrasound of the eye to see if there's any detachment, anything like that. So yeah, you can look past it.
Got it. And the last question, Dr. Sakina bhen, in the era of online webinars, Zoom meetings, do computers damage your eyes?
Not really. They don't damage your eyes in the sense that, look, you have to be smart about it, because if you're staring at something for hours and hours, your muscles get locked into that position. So just like imagine you're carrying a weight, and if you just hold it there for like 2 hours, the muscle is going to get, it's going to go under spasm. Same thing happens in the eye. So what you have to do is keep it flexible. So every 20 minutes or so, you look away and refocus on an object far away. And then every hour, I usually tell my patients, get up, get a drink of water, move away from it. That will keep it healthy. Now, I know there's a lot of talk about blue light. Blue light's everywhere. Look, it's in the sun. Sun is a big source of blue light. See what happened, the whole blue light thing came about is when the kids went on Zoom, okay? So kids, they were not used to being exposed to so much blue light, and then it started affecting their activity, their sleep cycle, so it's more the circadian rhythm that it affects, but just a normal person, if they're not having any symptoms or trouble sleeping, then you're fine. Again, dry eyes are another big problem from computer use. It's because people stare at the screen for hours and hours. And what you don't realize is that you're not thinking enough, okay? Because when you're focusing on something, you're just staring and you don't realize that you're not so conscious of, blinking helps. So movement, you wanna move the eye focus. And I always tell the kids that play games on TV, less on the computer, the better. And sometimes just using reading glasses to take the stress away will help with headaches and stuff like that. But computers are not bad for us. You just have to use them the right way. Okay.
All right. Thank you, Dr. Sakina bhen Jamali. We would like to thank all the audience je aje attend kidu a webinar ne. Thank you so much for taking time off and attending this webinar. Dr. Sakina bhen Jamali, આપનો બી ઘણો શુક્રન from Safi Burani Medical Association's Managing Committee. Thank you for taking your time and presenting this very important topic. અને આખિરમાં દુઆ કરીએ છીએ કે ખુદા તાલા અલી કદર મુફદ્દલ મૌલાની ઉમર શરીફને તારોઝ કયામત દરાજ અને દરાજ કરે. આમીન.
Amin.
શુક્રન સગલા. ખુદા હાફિઝ.
Shukran, Hatim, bye. Hello, sorry my message joined. Oh no. Okay. Okay. Am I still on air, Nina? Okay.